we can move on to the live in the box or recorded case. I will hand over now the word to Emanuele Gallinoro, who's introducing the case. Emanuele, please.
Thank you, Emanuele. I will present the case. So the case I'm going to present has been recorded in the Cardiovascular Center in Aalst, Belgium. The patient is a 72-year-old lady with diabetes, dyslipidemia, and obesity. She had recently an inferior STEMI in December 2020. The culprit lesion was located in the proximal right, as you can see from the left coronary angiogram. And on the right, you can see the final result after the implantation of a 323 stent. But this was a case of a multivessel disease. Indeed, here we see that there is a moderate stenosis in the middle AD and a mild to moderate stenosis in the distal circumflex and in the first marginal branch. So our plan was to perform a physiology-guided PCI, so to evaluate the hemodynamic impact of this stenosis, and also to perform a post-PCI physiological assessment. Do you want to go on, Emanuele?
Thank you very much. And that's the way it starts, as usually. There is a calibration phase where we make the console, the Vivo Cardio console, speaking the same language of the MACLAB console. So once the aortic pressure is calibrated, we open up the fluid fill connector, and we get synchronous measurement of the aortic pressure. As we usually do after a primary PCI, this patient was taken back to the cath lab a couple of days later. We checked the patency of the stent recently implanted in the culprit vessel. And as you can see, the vessel was fine. The flow was fine as well in the right coronary artery. Let me take also this opportunity to thank Katia Van Kutsemanedi, who were the nurses helping us during this recording. Now, this is the right coronary artery. You will see now the left coronary artery. The quality is a bit better as the one seen in the slides. And you can appreciate these intermediate stenosis in the mid-circumflex and in the first marginal branch. Now we move to a cranial view where you see this long lesion in the medial AD. It's actually a little bit longer if you pay attention than what we see on the angiogram. The disease starts even earlier than the first diagonal branch. Let's see in this angiogram. So the disease starts before the diagonal branch and goes way beyond the ostium of this side branch. In this specific moment, we took as a guiding catheter an EBU 6 French. We are transradial right in terms of vascular access. And this is again another projection that makes you better understanding the anatomy of this LAD lesion. There we go. Good, Eugenio.
Thank you. Okay, let's do a quick round of opinion. Ferrara and then Naples. How would you manage this patient, Simone?
So for the non-culprit lesion, I would have tried to acquire a projection for an angio-based FFR reconstruction during primary PCI, and then I would have tried to perform the analysis offline after the procedure, and then if positive, took back the patient in the cath lab.
Okay, Luigi?
Yes, this is a nice case example how the things goes in the cath lab. This is interesting. I seen that your first injection was on the contralateral vessel in respective of the STEMI. So you performed before the angio of the non-culprit vessel and then the PCI or the carpal lesion. This is how exactly perform also the primary PCI in my current clinical practice. Actually, I would have performed the FFR in the acute setting. This is what I have been. This is what I would have done in this case, because of the risk of finding, of course, non-significant lesion, and then the risk of taking back the patient on the table again a few days later.
Thank you, Luigi. So I think we can go back again to Ernst. So please, Emanuele.
Yes.
Thank you very much. What we did in this case, we took the patient back, as we said before, and we started the functional evaluation of the circumflex. What is the advantage of the TruePhysio microcatheter? You use the guide wire you want. We used, in this case, a BMW wire that we position in the circ. We are now ready to take the microcatheter. What we do to start with, we unpack the device. We flush with saline, pure saline, the plastic hose that contains the microcatheter. And then we connect the microcatheter to the console, as you see done in this moment. There we go. On the display of the console, there will be popping up this 0 PD. All what we have to do is to push on that. And we are now ready to introduce the microcatheter within the guiding catheter. You know, it has a short monorail that you can appreciate now that I'm loading the microcatheter on the guide wire. Let's follow this step. You know, it's a very tiny microcatheter, as Luigi was alluding to before during the presentation. This is really a good profile. It's so thin that nearly mimics the tip of a guide wire. And that is why I suspect this microcatheter can really advance and slide everywhere without any kind of problems. Now you will see the guide wire coming out of the short monorail, just to give you an idea of the monorail segment length. And now we introduce the microcatheter within the guiding catheter, much like we would do with any kind of monorail balloon. You know, once we are with the tip of the microcatheter at the level of the tip of the guiding catheter, you can clearly see where the tip of the microcatheter is, because we have these two radiopaque markers and the pressure sensor is just in between these two microcatheter. It is the moment to flush the system. So what I like to do on my manifold is to take out the syringe with contrast, take a new syringe and flush the whole system in order to make sure that there is no residual of contrast within the guiding catheter that can dampen the pressure tracing. At this very moment, I perform the equalization by simply pushing on that button. The two pressure, the aortic pressure and the pressure measured by the microcatheter, are perfectly superimposed. At this moment, we are ready to advance the microcatheter. All what we have to do, because we already have in mind the localization of the stenosis, we have to advance the microcatheter and induce hyperemia. Now, in our case, we use intracoronary papaverine. And you know, papaverine and contrast do not really go well along. So if you have to inject papaverine, you have to make sure that contrast is flushed away. And that's what we did from the beginning. Now, we start recording and we inject the bolus of papaverine. You see, that's the advantage of combining microcatheter with papaverine, because we don't have to use again contrast when navigating the pressure wire within the coronary artery. The guide wire is there. All what we have to do is to push the microcatheter this stop. This is the FFR. Yes, please.
Sorry, Emanuele, just a quick question. After papaverine, do you flush with saline or just you inject papaverine and you wait?
No, we flushed with saline. As you noticed, Simone, I injected 3 cc within the dead space of the guiding catheter. And when you saw me injecting with saline, it was just pushing forward the papaverine that was already in the dead space of the guiding catheter. So it's in a way, yes, to give you an answer. So there we go. This is the assessment of the circumflex, 0.92. At this moment, all what we have to do is to pull back the guide wire and go to the marginal branch. Now, we record the first measurement, 0.9, as we saw on the console of the microcatheter. Now we move on. At this moment, I need contrast, and I asked to Emanuele to inject some contrast because I'm navigating the wire, repositioning it. But that is the only moment I give contrast. Once the guide wire is in place, I already know where the pressure sensor should be located in order to assess that particular lesion. So again, the two markers at the tip of the guiding catheter, let's remember the sensor is located between the two markers. We check again the equalization. There we go. I already flushed with saline. In the interest of time, it's cut from this video. I advance the microcatheter. Okay, this is the resting PDPA. And there we go again. Papaverine in the dead space of the catheter. I ask to the nurse to push on rec. There we go. Now we are recording. I wait a few seconds to have resting PDPA recorded, 0.98, 97. Open the stopcock, inject saline, pushing forward the papaverine that is already in the dead space of the guiding catheter. And now we observe now the hyperemic response. Please notice also the time of each measurement. Less than 1 minute, actually, the first one. The second one, we pull back, we check the equalization, we check actually if the two pressures are going back to 1, and then we stop recording. So this was also not significant. Now, what you see here, 0.73, that's actually an error that the system does in detecting the maximum pressure gradient between the aortic pressure and the microcatheter pressure that we can correct afterward in data archiving, but I'll share this with you at the end of the session. Now, the second lesion is also non-significant. We reorient the guide wire towards the LAD. We change projection, as we all do in our daily practice, and we advance the guide wire to the LAD. Very safely, always with the same B&W wire. Cranial view, again, the microcatheter at the tip of the guiding catheter. We reconnect papaverine at the stopcock. We take another syringe with saline that we connect at the other stopcock of the manifold. That's what I'm asking to Emanuele. There we go. We make sure that the contrast that is in the guiding catheter is completely flushed away. So a couple of, you can also see that the composition of the syringe with papaverine is different, the density from the composition and the density of the saline. Now the system is ready. We check the equalization again. Eddie, our nurse, pushes on equalize, but you see it's always 1. We just do it in the interest of education. So PDPA is 1, equalization is correct. Then we advance the microcatheter into the distal LAD. I know exactly where the stenosis is, as I use the radiopaque part of the guide wire as the landing zone, if I may say so. Now we are distal. At this point, I ask to record the pressure tracings. You will see that shortly the record button will turn to rec. There we go. And now we inject papaverine in the dead space. Actually, it's at this very moment that I push on record. There we go, in order to have a clean measurement from the beginning till the end. Now we are recording. That's the resting PDPA 0.86, 0.87, 88, okay? And you saw now that the aortic pressure is just interrupted shortly because I injected papaverine, and now we see the hyperemic response. It's going down, 0.84, 83, 81, 79, and I guess the lowest value will be around 77, 78. But you see there is a significant hyperemic gradient. There we go. We stop recording, and what you see, it's a snapshot. Yeah, the lowest value is 76. You will see a snapshot that the system recognizes as maximum pressure gradient. Of course, I do the pullback also to see where most of the hyperemic gradient is located. We stop recording, equalization is more or less okay. Voila, it gives you 0.63. Again, it's the usual trick that I mentioned before, that the system detects, captures the maximum pressure gradient. That doesn't mean that is the correct FFR, but in the data archiving phase, we will demonstrate how to pick the correct pressure gradient also for future recordings. Eugenio.
Perfect, thank you, Emanuele. I'm now curious to know how in Italy we induce hyperemia. So please, Luigi, which drug do you use? And then Simone.
Well, actually, we currently use adenosine, most of the time adenosine, even adenosine IV.
IV, perfect. Simone?
Adenosine IV also. We on all the cases. Yes.
Thank you. So please, if we have some questions for Emanuele, we can start from Luigi.
Yes, Emanuele, thank you for sharing this nice example of a patient with multivessel disease and several lesions everywhere, I must say. I was wondering why you did not measure the FFR in the first diagonal branch.
That's a good point, Luigi. Actually, physiology in bifurcation lesion has been investigated, but not in the sense of truly guiding PCI of a bifurcation lesion. So in other words, if you measure FFR in the LAD and in the diagonal branch, that is not predicting what will happen in terms of functional significance to the diagonal branch all the way through the PCI. In other words, if I stent the main branch and I have a significant plaque shift towards the diagonal branch, FFR pre at baseline does not predict what will be and whether there will be a significant plaque shift. So rather than investing time in measuring FFR into the diagonal branch at the beginning, it's much more useful to do it just at the end.
Thank you.
The PCI.
Perfect. Simone?
Yes, I have a very practical question. You almost already said it, but is there any difference in terms of protocol of FFR performance with the microcatheter rather than the conventional pressure wire? Or it's the same actually?
Well, that's a very important point, Simone. We should try to always have a standardized protocol when doing invasive physiology. Always we have to be consistent, repeating always the same step. And as you saw throughout the procedure, we roughly did the same steps as we would do with the pressure wire protocol. So correct equalization, flushing the contrast out to avoid dampening of pressure, and inducing hyperemia, pulling back, checking whether there is any focal versus diffuse disease gradient, but you will discuss this later, and check always whether the two pressures, whether the equalization is correct at the end. So in a nutshell, it's exactly the same protocol as compared to a pressure wire-based physiology.
Thank you, Emanuele. Now I'm curious because in Italy, we use adeno IV. You used papaverine. So my question is, how long hyperemia lasts with papaverine? And how is the methodology to use papaverine?
That's a very important practical question, Eugenio. Papaverine has the advantage of having a longer half-life as compared to adenosine. And the hyperemic response of papaverine IC is longer as compared to the hyperemic response of adenosine IC. So just to give you a magnitude of reference, with adenosine IC, the maximum hyperemic response lasts between 50 to 20 seconds. With papaverine IC, it can go up to 1 minute. What does that mean practically? It means that you can perform nice pullback curves even during the maximal hyperemic response. With adenosine intracoronarily, that's not possible because by the time you get the maximal hyperemic response, you don't have the time to do careful pullback. And second advantage, as compared to adenosine IV, is that you don't have to wait 2 to 3 minutes to achieve a maximal hyperemic response, as it is the case in the IV infusion.
Thank you, Emanuele. Let's go for a last question for you, Simone, please.
Yes, another practical question actually, because when you perform FFR pullback, you have to go through the vessel at least twice or thrice, and then every time you're not so sure that you are in the same position as before, and that you can interpret the pullback in the same way. So do you think this can be different with the microcatheter? Is this a meaningful difference or not in your opinion?
That's a major difference between a pressure wire based physiology and a microcatheter based physiology. As I tried to demonstrate before during the case, you place your guide wire, your workhorse guide wire in a certain point in the vessel, and you have the radiopaque tip of the guide wire as a reference. You know that depending on the guide wire, it's 2 to 3 centimeters long, this radiopaque tip. So if you decide that your starting point of the radiopaque part of the tip is your landing zone, then you can be consistent that that landing zone will remain the same all the way through the assessment in the case. With pressure wire, how we do it currently, and you are experts, so you know better than I do, you have always to check with contrast. You take an angiographic landmark, a side branch, a diagonal or septal branch, you position the pressure sensor there, and you keep in mind that it has always to be there. So each time you go in and out with your pressure wire, you have to give repetitive bolus of contrast. That's a major difference between the two systems.
Thank you, Emanuele. Luigi, do you have a last question for Emanuele?
Yes, thank you, Eugenio. Well, it was impressive how the drift was always less than 3 units in all your measurements. Do you think this might be related to the fact that you don't have to manipulate too much a pressure wire, but just to have to push the microcatheter forward? What do you think?
That's certainly one of the reasons, Luigi. What I would also add to this one is that the system is more stable and clean. With that, what I mean, contrast, the presence of contrast on the pressure sensor itself is one of the reasons for drift. The fact that the system is cleaned with saline from the beginning of the recording till the end of the pullback makes you taking out one of the possible factors to drift. In addition to the technology, of course, that this MEMS technology that the microcatheter has make the signal very stable, I must say. I never happened to really see a major drift, honestly, with this device.
Thank you, Emanuele. I think it's time to go to Art again to see the procedure.
Yes, here we go. Okay, so basically then for the PCI, we place 2 wires, 2 BMW, one in the LAD, and the second one in the first diagonal branch. Then we used a semi-compliant balloon, a 2.515 for the predilation of the lesion. The balloon was inflated up to 10 atmospheres in order to achieve a good lesion preparation. And then the stent was advanced quite easily through the lesion. The stent is a 2.75, 33 millimeters. We placed it carefully in order not to leave any residual plaque at the proximal or at the distal edge of the stent. So we placed it carefully under fluoroscopy. And then the stent was deployed and the balloon was inflated up to 14 atmospheres. Then we retrieved the balloon of the stent and we performed a POT, a proximal optimization of the stent expansion with a non-compliant balloon at 312. Also, in order to facilitate afterwards the wire exchange. So this non-compliant balloon was inflated up to 14 atmospheres. Then this is the result. Then we performed the wire exchange. So basically the wire from the LAD was retrieved. The tip was kept in the stent, and we crossed the stent struts in order to place this wire in the diagonal. And here we go. And then now we have the wire that was previously placed in the first diagonal that of course is jailed. So then we pull back the gelled wire from the first diagonal carefully, because we always have this movement that the guiding catheter tends to go deep in the coronary artery, and then we place this wire in the distal LED. So after the wire exchange, we perform the kissing with the semi-compliant balloon 315 placed in the LED and the 215 placed in the first diagonal branch in order to better open the struts of the stent towards the first diagonal branch. And then, of course, we finish with the final pot with the non-compliant balloon 312. Also, in this case, we used the stent beads in order to place properly the balloon. And you can see from the stent beads how the struts of the stent towards the first diagonal branch are well open. Then we inflated the balloon up to 18 atmosphere for the final pot. So basically we perform the pot, kiss, pot strategy. And here you can also see again the final result with the stent beads. And here we see clearly the struts of the stent in the diagonal branch. So
thank you.
Okay.
Thank you, Emanuele, for the case. Now I'm curious to know, with my colleague in Italy, what are your attitude to do post-PCI FFR? Simone, please.
Yes, I must be very, very honest. In this case, maybe I would have done on the LAD, but surely not on the diagonal branch. Because, I mean, it would have been not so easy to cross with the FFR wire in the diagonal. And so I think this is the way I would have managed it.
Thank you. Luigi?
Yes, I have to say the same as Simone already told us. Probably I would have measured just the LED and I would have performed the pullback in order to see what is the impact of the stent of the entire functional assessment of the vessel. And I would have never measured the diagonal branch after the kissing and after the pot.
Thank you, Luigi. So let's move to have some question for Emanuele. Simone, can you jump in?
Yes, absolutely. What it surprises me is, I mean, how feasible the system is. So if I think to do the same with the conventional pressure wire, I have to disconnect and reconnect and clean with the gauze and then remove the contrast from the bottom part of the wire, and then the connection is not always working, and I lose time, contrast, X-ray. So what is your feeling about this difference in this case and in your experience with the system?
Indeed, Simone, this system introduces a significant degree of simplification in our invasive functional assessment. And simplification goes exactly for the steps you just highlighted. The simple fact that you don't have to connect and disconnect in case you would use the pressure wire also to perform PCI, but some other operators might also inquire by saying, you know, I use pressure wire only to assess and not to treat, depending on the complexity of the lesion. That is already a major step forward. So the microcatheter is always connected to the console. So all you have to do is to keep it clean on the table and introducing it back the time you need it. And that, of course, contributes to the quality of the signal and to the lack of final drift that was alluded by Luigi before.
Thank you, Emanuele. Very clear. Luigi, do you have any comment?
Yes. Well, the way you, Emanuele, performed the crisscross of the wires is impressive. And probably if you would have used a pressure wire for the PCI or the main branch, you probably would have never crossed the stent struts through the diagonal branch, and you probably would have asked for a third wire. So this system probably allow us to spare not only contrast and time, but even material.
That's very well said, Luigi. We know the quality of the pressure wire has improved. Nowadays, they are really slippery, they are hydrophilic, and they can easily be handled, but is never the same quality of a workhorse guide wire. This we know it very well. I would never dare, for example, to jail a pressure wire behind the stent struts, especially if you are in a calcified lesion setting. You never know. These are two separate bodies of the wire, of the technology, so they can easily disconnect. And that is what you avoid by using this system. You can forget whatever wire you're using. You can just use your PCI wire, and then afterward do your assessment by going in and out with the microcatheter. In addition, having good quality wire also allows you to be within the vessel without the fear to go subintimally. You know, when a guide wire is not well performing in a side branch that has been treated with kissing balloon, you never know whether there is a little intimal tear in which you can fall if the wire is not freely moving. And this system avoids this potential risk.
Thank you, Emanuele. I think it's time to see the final part of the case. So please.
Yes.
Emanuele.
Yes, here we go with the final part.
Thank you.
So
we did,
please, Emanuele.
Thank you, Emanuele. We did post-PCI evaluation. Again, microcatheter at the tip of the guiding catheter. We check the equalization. It's 1 at this moment. Always consistently, same protocol. We advance the microcatheter up to the landing zone we've given us in the beginning of the physiologic assessment. We close the stopcock, we close the valve of the guiding catheter. We see again the two pressures are up. This is now the resting PDPA. There we go. We flush the system with saline. We start recording. Few seconds to record the resting PDPA. At a certain point, you will notice that the aortic pressure interrupts. We inject adenosine. There we go. And we get the hyperemic response in the vessel. So this is the first information. FFR post is 0.93, so way above ischemic threshold of 0.8. And at this moment, we do the pullback that gives you a second information, how much I can improve this post-PCI FFR. Is there any residual focal gradient that I can treat with an additional stent? And what this pullback tells us, we stop the recording in a short while, what this pullback tells us is that there is diffuse residual disease. So there is no way I can improve this residual grading by additional stenting. And last information, the measurement was correct because the final PDPA was 1. Now you see we are going without any problem to a diagonal branch, and it took us no time to get into the diagonal branch without any effort. And at this moment, again, we flush the system, we induce hyperemia, we ask our nurse to push on rec. There we go, we are ready, we inject the hyperemic stimulus inside, and we wait for the hyperemic response. So towards the diagonal branch, the FFR was 0.90. Again, we do the pullback, and we see again this diffuse gradient all the way through with a good equalization at the end. We stop recording, and what you saw again, it's this artifactual number that I'll explain you in a while how to correct it. Final angiographic acquisition here. I would say good angiographic result, good functional result, 0.93 in the LAD, 0.9 something in the diagonal branch. We are finished. Now it comes a very important moment, data archiving. This was one of these artifactual measurements. Why? Because the system takes the measurement where the simple volume is located. So all what you have to do is to place the simple volume at the stable hyperemic response, push on the FFR, recalculate, relocate the FFR, and that gives you the right value. In addition, if you want to revisit the measurement, later on, days after, you need to recall what you did. So tell the system whether you measure the LAD, the circumflex, the marginal branch. So there is some legends in the system. Tell the system whether it was pre-PCI, post-PCI, whether you used adenosine, papaverine, because this information will be useful later on. And at the end, you can review all your measurements, 4, 5, 6 measurements. You see how many we did. And each of them did not last more than 1 minute. So we did a multivessel disease functional assessment. I think we can stop sharing the screen. We did a multivessel disease functional assessment without any further waste of time. In total, 1 minute each. So in 5, 6 minutes, you have pre and post PCI assessment and evaluation.
Thank you, Emanuele. Really impressive. Impressive about the time that you see on the screen and how much is user-friendly this device. I give the words to my colleague, Luigi. Do you have any question for Emanuele?
Yes, thank you, Eugenio. Well, I've noticed that the passage of the TruePhysio microcatheter was extremely smooth even across the diagonal branch after kissing and the pot. Can you give us some feedback about this peculiarity? And in addition, what do you think the potential role? What about the potential role of this microcatheter for the assessment of coronary bifurcation, especially for the left main, where the new mantra seems to be the decay crash?
You know, left main is a different kind of bifurcation where you would like to achieve a nearly perfect result. But that is a kind of assessment that I would do honestly with intravascular imaging in left main rather than functional assessment. Nevertheless, if we are talking about stenting technique, crushing technique or mini crush implies different layer of metal that are pushed on one side of the vessel, as we know. And these layers of metal are not always easy to cross and recross, especially if we want to do final kissing balloon. But nevertheless, it is extremely important to assess the final functional result. Why? Because if we decide to do mini crush technique, you have certainly few millimeters of the side branch that are diseased as well. So it's not like in this specific case that we just showed that we opened the stent struts towards the side branch, but there was not much of disease in the side branch itself. But when it comes to true bifurcation lesion, where both the main branch and the side branch are diseased, having a technique that enables you easily to go in and out the main branch and in and out the side branch to assess the final stenting result from a functional point of view is certainly an added value.
Thank you, Emanuele. Simone, do you have any question for Emanuele?
Yeah, so basically this was almost a live procedure and it took 20 minutes. So, and you perform, if I'm not wrong, 5 functional assessments. So I think that this is quite astonishing for me to perform such a good functional evaluation in a short time. I don't know if you can comment a little bit on this.
Simone, that is actually what a novel technology should do, should make things simpler and should also make them quicker. Just guess for a minute if we would have done this procedure with a pressure wire. Can you imagine to cross and recross a stented segment? You know how many times it's difficult because the tip of the guide wire hits against the stent struts. So we have to pull it back, talk a bit, advance, hoping that we would not enter the vessel wall because this occurred as well. So we did this not only in the main branch, that was rather a straight segment, but we did this also into the side branch with really no extra time and no extra effort.
Thank you, Emanuele. Can I ask you, you know that our job is to restore the epicardial function, conductance of the vessel. You did FFR pullback, but now how do you say that the FFR that you achieve is correct?
Well, I don't want to preempt the nice lecture that Simone is going to give after this bit of the session. But you know, the higher the post-PCI FFR value, the better. It's a paradigm, but it's not always achievable. I think what is important is to check whether we can further improve post-PCI functional result. How? Checking whether there is any intra-stent residual gradient, and Simona will tell about this, and checking whether there is any focal residual gradient beyond the stents or upstream to the stent that I can further improve it by implanting additional stent. Having said that, we have to be very practical. Try to improve what can be improved, but always keeping in mind that the longer the stented segment, the worse the clinical outcome for the patient. So we should also try to avoid to have a full metal jacket at the end of the procedure. There has to be common sense.
Thank you. Very clear. Luigi, do you have any last question for Emanuele?
Yes, not because I'm addicted to do the side branches, but actually I just want to know, in case you measure the side branch, which value would you like to reach, or do you rather prefer to take care about the angiographic result and that's it?
You know, let's again be very practical, and I don't have clinical data to support this statement. But what I'd like to see from a functional result in a side branch is that the FFR value would not be lower than the FFR value that I measure post-PCI in the main branch. Because if that is the case, we are in trouble. Let's not forget that the side branch has upstream the main vessel. So what I expect a post-PCI FFR in a side branch is to tell me the impact of the arteriosclerotic burden that is upstream to the side branch in the final FFR measurement. If that is the case, I'm happy with that.
Thank you, Emanuele.
The Insight LifeTech Vivo Cardio and TruePhysio FFR and CRR measurement system can facilitate your measurements with simplicity and accuracy. More rapid, accurate, and stable to transform healthcare through innovation and quality.